I welcome on stage our next presenter, Dr. Vikram Kate, who's going to show us a robotic right hemicolectomy.
Good evening to all, and at the outset I'd like to thank the organizers for giving me an opportunity. This is the first time in the last 3 decades I'm presenting a video as a lecture. Now this is a 49-year-old female, came with features suggestive of anemia, weight loss for 3 months, and colonoscopy showed us circumferential growth. And what we can see here is an ascending colon mass on CT. This is the position, 10 degree left tilt, 10 degree head low. We have an XI system. And this is the port position. These are the 4 ports. As in XI, once we have targeted, we have to put it in a form of a T. And the distance between the targeting and the camera port, as far as possible, try to keep as much. The recommendation is about 18 centimeters, but 15 to 18 can be kept. And between the ports, you should try to keep, if it is possible, it's a wide abdominal wall, about 8 centimeters. The collision is a big problem when we are doing with robotic. So we use the ProGrasp, it's in the 4, the upper tip, the fenestrated, that is turned around like that. At the IC junction, we give traction so that we can see the ileocolic pedicle. So with the traction, the ileocolic pedicle becomes, the mesocolon becomes prominent, and in some time we'll see the ileocolic pedicle. So the left, at number 1, we have the fenestrated bipolar, what is the seen in my right hand, in my left hand, and the right hand we have the monopolar scissor. Can you go a little bit, rewind it? Maybe a little bit more, maybe half a minute more, yeah, that should be better. Yeah, so this is what we are seeing, the traction there, and in a matter of time we'll see the ileocolic pedicle. You can see here fenestrated bipolar in my left hand, right hand monopolar scissor in between the camera, and this is what is the fenestrated, the tip of fenestrated forceps or ProGrasp, anything can be used there. That is ileocolic artery. We are not particularly going more onto the left and skeletonizing the superior mesenteric artery. Hemologs have been put. This is what is important, that we should not go beneath the Tal's fascia here, otherwise the ureter and the gonadals will get exposed. So this is the peritoneum, and at this place we should go up. Now what we see, if you go into the correct plane, I don't know whether the color appreciation is there. You can see the color change. This is the retroperitoneal fat there, and that is what is the mesocolic fat. When we see it under the robo magnification, and the color is extremely good, and we can see the difference between the fat, that's the duodenum. To get a very correct plane of the mesocolon, and you can separate the mesocolon from the retroperitoneum to get a good mesocolic plane. That's all the duodenum which has been dissected. And over a period of time, we'll see the right colic vessels. Right colic vessels are not consistent. Sometimes you may see it, sometimes you may not see it. Here it is visible. This is medial to lateral. The steps are identical to laparoscopic surgery. Only thing is the clarity magnification is definitely very good, and since it is under the control of the surgeon, so this we have gone through and through, it becomes relatively easier. Oh. The tip of grasper is good for retraction and giving traction there on the mesocolon. That's the duodenum and the pancreas. And that is where we'll see the right colic pedicle. This patient had a accessory right colic vein. After this ligation, we can see that. Now we have to give good traction for the transverse mesocolon. This sometimes can be challenging. Too much of mobility of the organ becomes a problem in robotic surgery. That's the right branch of middle colic. We have taken it together. Artery and the vein. This patient had ascending colon, so we have not gone up the route of the middle colic, and now we are mobilizing colon for the gastrocolic omentum. Lastly, the mobilization of the cecum and the ileum, and we do a extracorporeal anastomosis. That is what we do. Put a linear stapler and then anastomose it. Thank you very much for your kind attention. I hope it was visible because intermittently the video was shutting down, but I think overall it was seen.
Thank you, Dr. Kate. Without trying to be repetitive, has been going on since morning, do you personally feel there is any superiority or advantage between the laparoscopic and or the robotic versus the laparoscopic approach, especially for right hemicolectomy?
Okay, I'll go a little out of the way to answer this. Morning when we came back from the airport, I was with Senthil and we just discussing like how Dr. Nagnath Babu and three of us are talking about how the advances are being made. Just a little bit I'll expand onto the answer. That's why I'm saying I'm going a little out of the way. So what I feel is that, this is my personal opinion, that even though right now trials are being compared between robotic and laparoscopic, robotic is not uniformly available. The cost is there, restrictions are there. With great difficulty, I was talking to Dr. Mishra now. 5-6 years back, I started learning. Dr. Kalerasan, if I don't know whether he's here, he's my student and now he's my teacher for robotic. So I thought whether I should learn or not at this age, and ultimately I have gone into it and learned and done more than 100 operations in robotic, different types of operations. But what I feel is it's a matter of time. After 10-15 years, a lot of youngsters are sitting here, there will be no laparoscopic surgery. Because anybody who does robotic, they'll find out that if it is widely available, easily available, it's like endoscope or ultrasound. If it becomes, it will become, it's like a cell phone now, everything is free in that. It will become, you will find that when people start using this, I'll tell you that if it is available in each and every hospital, there will be no laparoscopic surgery. Because it is exactly like open surgery, everything is superior to laparoscopy, the vision, the control, everything. So that is what I feel, what people compare. What I am saying is here in this IASGCON in Calcutta, 15 years from now, if they hold it here, there will be no laparoscopic surgery video here. That is how it will be, because it is like that. It is exactly like what you do in open surgery, and once you learn the anatomy, which right now people who do laparoscopic surgery, that's the only advantage. I hardly did any laparoscopic surgery. That you need to know the anatomy by which you do a laparoscopic surgery. Otherwise, exactly the way you do open surgery you have to do, and the robo has more controls than even open surgery, the wrist movements and all those things. So that is what I feel. That's the advantage. Once, because everybody has to learn. These people 10 years from now, 40, 45, there will be no lab. It's like right now many procedures there is no open for that. That is how it will replace. And it might become so superior. Today we were talking in the car that when you put AI into the robo, you don't have to go to the OT also. The robo will do the surgery. So there is no need for surgeons also to sit here, because once you put AI into the robo, there is no need. Absolutely top surgeons can put into it. You just press a button and say that do right radical hemicolectomy. It will do in such a perfect manner that surgeons may become extinct.
You need to decrease seats then, sir. I think I'm glad you said that. I think if you do a robotic surgery...
just a second, sorry to interrupt you. I am not saying this is my statement. This Dr. Nagnath Babu said this is a statement of a British surgeon who is a top expert in AI, artificial intelligence. He said this.
I think if you start doing robotics, you would love doing the procedures, and especially for the right hemicolectomy, there are 2-3 comments I would like to make. One is, I usually prefer harmonic as compared to the monopolar scissors.
Very expensive.
For a LAR, I prefer a monopolar scissors, but for a...
Anytime if harmonic is there, nobody will use monopolar.
Yeah.
But it is, I think, how much is it? 35,
LAR,
40
I would still
single
prefer
use.
a monopolar scissors.
Yeah.
And also with the robotics, there are 2 things which we have done. If you use the Sureform staplers, they are the staplers which can be guided. You can do a good intracorporeal anastomosis, since the suturing is much more easier. So you are more comfortable doing an intracorporeal anastomosis, which you are not with...
That I have done in Atlanta when they provided free of cost.
Yeah.
That's the only one I have done when I went for the training there. It was intracorporeal, and as you said, they gave a slot for 1 hour. I was thinking 1 hour, how will I do a hemicolectomy for radical hemicolectomy? 45 minutes to 1 hour, you can finish that, what you said, if you have that facility. But I think the cost, we are not using it in JIPMER, so I think it is 35 to 40 with a single use, is it not? That's how it is. How much? 75,000. So that's the problem. That is why everybody, this has become the gold standard, that we have advanced to harmonic everywhere, and now we are coming back to the monopolar cautery for doing this surgery.
Anybody else?
No one else, right? Thank you, Dr. Vikram.
Thank you very much.
And as you said that 15 years from now, this is going to be a robotic conference. Well, and if surgeons are extinct, this is going to be an AI conference. So you have to think about that.
Yeah, possible. As I said, if robotic is used for most of the procedures, and if AI can manage that the robot performs independent of the surgeon, then that is what is another discussion we had, that when if you say that the robot is performing the surgery, then the patients are asking the surgeon, then what are you doing?
Exactly.
That is what they say.
Thank you very much, sir.
Okay, thank you.
Thank you.